So thanks again to be here. As I told you by email, we are a group of people, but mainly of hospitals in Italy. It's called Fenice, and we are focused on the clinical research in particular for the topic of emergency medicine. And in the last month, we organized different kind of this lecture and debates on some particular clinician topics. And the last time the last week, we had a great debate between two groups of residents, one from Bologna and one from Udine. And I have to say that it was really, really interesting about, of course, your article, because those girls were really good in, of course, explain the article, but also giving us the pro and cons of your thesis, and also regarding the statistical part that was not easy to understand. It was a great you done a great job, and the girls too did a great job in giving us the idea of your article is about. But today we are here to see your to hear your voice, and I hope that at the end of your explanation, those girls or other people from the public can say something and ask you some question, because the last time there was a lot of discussion, many questions after the presentation. So I hope that today we can have the same. Thank you.
Awesome. Well, thank you so much for having me. And the idea of just debating all this is such a fun idea. So thanks so much. I will go ahead and share my screen. Can you see my slides here?
Yes.
Great. Hopefully this will be pretty brief and then we can get to the discussion, but I'm just going to tell you a little bit about this article. So I'm a health services researcher at Boston University and an epidemiologist. And my goal is to see if we can use observational data, big data to try to help to inform the decisions we make all the time now in the ICU in particular, and I'm a pulmonologist and an intensivist by training. So this is the talk I'm going to be going over. These are all just grant funding disclosures, but nothing else, nothing related to this study. And so this is the article that came out in JAMA IM a couple months back. And I wanted to start off this talk with talking about how this study came to be. And I think it really highlights some of the benefits of doing collaborative research. And so we were asked to, our research group was asked to write an article in Chest about how we escalate vasopressor therapy in corticosteroids and septic shock. And we were meeting to discuss how we were going to go through a case-based discussion, you know, starting on norepinephrine, and then when do you add vasopressin, when do you add corticosteroids? And we got to the corticosteroid section, and we disagreed a lot. There were several of us in the room, and there were two of us, Alan Waukee and Bijan Teja, who said, we use hydrocortisone and fludrocortisone all the time. Of course we do. That's what the trials show. That's what we're supposed to do. And then there were several of us, this is Annika and Brandon, who are part of the team, and they said, oh, no, we just use hydrocortisone. Why would you use both of them? And there was clearly evidence of practice pattern variation, even in our small study team. And despite that, people had strong views on that. So that's what gave us the idea to start on this project, was just recognizing that we were doing very different things, even though we all read the same evidence. And so that meeting really led us to dig into the literature. And I'm sure you all know this, so I'm going to be brief here. But the main trials supporting the different regimens in septic shock are Anand in 2018 and then Venkatesh in 2018. And these came out in the same journal of NEJM at the same time. And one of them, the Anand trial, showed mortality benefit with combination treatment versus placebo. And Venkatesh compared hydrocortisone to placebo and found no difference. And there was also a very large difference in the baseline placebo mortality rate. So for Venkatesh, it was around 30%, and for Anand, it was up to 50%. So probably different septic shock populations. As we all recognize, septic shock is not the same disease. It's different. It's heterogeneous. And so that these populations may or may not be comparable, but at least there was some evidence saying that septic shock mortality was improved with combination treatment. And both studies found that shock duration decreased with treatment. So those studies, and that's not the only evidence. There's evidence for decades about what's the right treatment for septic shock with corticosteroids. But the Surviving Sepsis guidelines in 2021 supported using hydrocortisone alone, IV hydrocortisone. And then Up to Date, which is at least in the US, a common practice assistance source of information. We use this a lot. Also supports using hydrocortisone alone. And so specifically here in Up to Date, the authors say, although some trials added fludrocortisone, we don't typically do this because we believe that hydrocortisone alone has sufficient mineralocorticoid effect, and absorption of the enterally administered drug is questionable in situations of compromised splanchnic perfusion. So our decision is supported by others and a trial, and I'm going to talk about this trial a little bit, that said that there's no difference in outcomes. And so after reading, we knew about the trials, we knew about Up to Date, we knew about the Surviving Sepsis guidelines. We decided to dig a little bit deeper to put it in context. So when Up to Date says supported by others, the decision not to give fludrocortisone is supported by others. And their citations include this study. So from 1992, that was basically just a review article that said that the sodium retaining effect of cortisol, which is what hydrocortisone turns into, was like a mineralocorticoid at 12 hours. And if you keep on digging through the rabbit hole, you find the source material, which is 1982, a study in rats looking at mineralocorticoid receptor binding of different glucocorticoids, including cortisol. And so I think just another example, I think the opioid epidemic is another one about opioids being safe and non-addictive. This is another example where if you go down the rabbit hole of citations, you don't see clear evidence that that hydrocortisone alone is somehow replacing fludrocortisone, but it does seem to at least have a sodium retaining potency in the kidney. So if we think that the mechanism by which hydrocortisone and fludrocortisone in septic shock is mediated by its effects on reducing on salt intake in the kidneys, then maybe hydrocortisone is enough. And I think that's basically unclear. And then just the last background information, this is overwhelmingly the most commonly cited study for why fludrocortisone and hydrocortisone, why hydrocortisone is enough. And so this was done by Anand and his group in France. And it was a 2x2 factorial design, which is why it's sometimes hard to find the literature. And so it's focused on intensive insulin therapy. But the takeaway was that this study was powered for the intensive insulin therapy group. So it was meant to answer a question about insulin, and they were hoping on this side we'll also answer a question about corticosteroids. And so what they found is they randomized a small number of patients to receive combination treatment or single treatment, and they found a risk difference, an absolute risk difference of just about 3%, 2.9%, and they concluded that that was not significant. And this is, kind of the normal problem with underpowered clinical trials is when you power a study for something else, intensive insulin therapy, and yet you find that there's no difference in a different treatment arm or a different outcome. It's unfortunately often inferred that this is truly no difference rather than underpower. And to put it into context, if this risk difference, 45.8 versus 42.9, were true, if there were a small risk difference in mortality based on these treatment arms, you would actually need 9,000 patients to enroll an appropriately powered study. And so this number is the limitation of RCTs. This is a large platform, multi-center, multinational RCT to get this number of patients, and we were hoping to use the methods we're familiar with to try to do it with observational data. So this is the summary where we were at when we started down the endeavor of going through this study. We think that people have strong opinions, and they should, right? People are trying to do the best they can for the patients. There's clear evidence that steroids improve shock duration. There's less clear evidence that steroids improve mortality, and that evidence is limited to the combination of hydrocortisone and fludrocortisone compared to placebo. And then that the best practice statements, the guidelines we have suggest hydrocortisone alone, but that's based on a mechanism that is in vivo data about sodium retaining potency in the kidneys. And so I think this was like strong evidence for us that there's a knowledge gap and that we should try to do something about it. And so why observational causal inference? Why big data? And I think it mostly comes down to bullet point 1. You know, you have lots more patients, so you can get precise estimates of treatment effect. These days, we have granular electronic medical record data that allows us to identify confounding and the timing of confounding, although it's limited, and I'll talk about some of those limitations. But really understanding what came first is an important part of causal inference because you can't go back in time. There's methods, including those used in our study, that are newer and potentially more resistant to confounding with some older methods like propensity score methods. And then really this target trial framework, and I'm going to touch on this a little bit more. I think that's the key to doing good observational research. And it's pretty straightforward, and clinicians should be helping with this in the sense that this is what allows us to minimize the mistakes that are often made with observational research, things like selection bias, mortal time bias, all of these biases that often get built into observational studies, you can minimize by just thinking through how your study is similar to what an RCT would be if you were conducting an RCT. And so that's what this is just Miguel Hernan is the big proponent of target trial emulation, and mostly it involves going through what an RCT, the eligibility criteria, the treatment strategies, how a treatment is assigned, like randomization, what are the outcomes, what's the follow-up period, and just doing the same thing with your observational study. And inherently by doing this process, especially if you get the timing right, that eligibility occurs before treatment and treatment occurs before outcomes, and baseline characteristics happen before treatment. All of those things, if you get that right, you really minimize some of the fallacies you can get into around residual confounding and selection bias. And so this is our table, our target trial emulation for our study. We wanted to include we're trying to mimic a trial that would enroll patients who were critically ill, that we defined as ICU or step-down patients, adults who had septic shock and were already starting on norepinephrine, which we thought was, although there's some practice pattern variation, that's a given these days that most patients should be receiving norepinephrine as first line. We wanted to include those that were early in their septic shock course and they weren't already receiving fludrocortisone. And then our treatment interest was hydrocortisone or combination of hydrocortisone and fludrocortisone. The trial would be randomization, but we could only observe what happened to patients. So that's really the inherent difference between observational studies and RCTs. And then our outcome was going to be hospital death or discharge to hospice. And we included discharge to hospice because we thought that those patients were no longer receiving care that was consistent with like vasopressors and other organ support. And then we had typical secondary outcomes like vasopressor-free days and hospital-free days that are meant to measure shock duration and length of stay while accounting for the competing risk of death. Because if you die, your hospital length is of course shorter, but that's not a good thing. That's a bad thing. And then I think everything else. And the last thing is the causal estimate. So typically in a RCT, it's an intention to treat design. In our case, it was actually both per protocol and intention to treat, because the way we designed our inclusion criteria is that you had to get hydrocortisone to be included in our study. So it wasn't that you got included and then that some of those patients then went on to receive hydrocortisone or hydrocortisone and fludrocortisone, which would be what an RCT was, which is what an RCT would do. Ours instead said, basically simultaneously, in a hypothetical world where an RCT could simultaneously enroll you and immediately start you on hydrocortisone. That's why the per protocol and intention to treat were the same, because those patients were the same. A little bit more into the details, and I'm methods heavy because I like the methods, but we used, this is a large data set. It's got 12 million people in it from these years. It's all US based. It's about 20% of all of our hospitalizations in the US. It is at its heart a claims-based data set that's based on diagnosis codes, but it also importantly includes charge codes. So we're able to the level of the day say whether patients got certain medications or procedures, whether they got radiographs, whether they got vital signs taken, whether they got labs drawn, those things. Unfortunately, we don't know the results of things like the labs, and that's definitely a limitation. And then I think I already went through the inclusion criteria and the outcomes. So confounding is always the problem with observational research. And it's true that even if you adjust and account for as many variables as you can measure, there's always residual unmeasured confounding. And so there's ways to try to potentially mitigate that. But just to show you, this is a directed acyclic graph. This is probably the, I think the current best approach to dealing with confounding, where you draw one-way arrows that show what you think are the relationships between potential confounding variables and your exposure and your outcome. And this graph, it actually has math behind that allows you to figure out what you should be considering a confounder, and variables that are definitely not confounders, but in some cases people have adjusted for other studies in the past. So just to show that there's many confounders in this study, and each of these little circles like sepsis severity represents lots of individual variables. So sepsis severity may be organ dysfunction, it may be mechanical ventilation, and those are all lumped together in each of those circles. The primary method we use in this study is called TMLE, targeted maximum likelihood estimation. It's a little complex, but what it comes down to is it is based on the propensity score. So that's a method that many of us have seen in the past. And the propensity score is just what's the probability of receiving treatment. So what's the probability of getting hydrocortisone versus hydrocortisone alone? And those methods have been available for a long time. The TMLE specifically has a couple of advantages, is that after it calculates the propensity score, it also uses G computation and modern causal inference to adjust the final estimate of the treatment effect based on the propensity score. And the second thing is it allows you to use machine learning, which isn't anything too fancy, right? Machine learning in general are just models that do the same thing that traditional models are. You have some variables and you try to predict an outcome. But the advantage of machine learning over parametric models like linear models, like general linearized models, is that they allow you to identify non-linear association. So I think for this, the machine learning, it's not like this is something fancy and special and it's going to change the world, but it does allow us to identify non-linear associations, which is how the real world works. It's not all, the world doesn't work in linear associations. And so we use this model to estimate the average treatment effect, which is the same estimate that a clinical trial gives. And usually that's reported as a risk difference or a relative risk. And the average treatment effect is in the causal inference framework, it's what's the difference in outcomes if everyone in your population had been treated versus a counterfactual pretend world where no one receives treatment. And then lastly, before we get to the results, I'll just say a really important part of observational causal inference and observational studies is doing sensitivity analyses, additional analyses, because the assumptions you make have drawbacks, right? Everything you do, every method that you use has potential limitations. And so you try to predict what those limitations are and address them by running additional analyses. And if all of your analyses pretty much line up, get to the same conclusion, then you can feel better about your results being the truth. And that may or may not be true. And so I'll run through some of my, sorry, 1 second, my dogs are barking. All right. I'll run through some of the sensitivity analyses in the results section, but the one I want to highlight is a negative control outcome. I think these are probably, everyone should be doing these in observational data. And they have their limitations, but they're better than what we've done before. And so what a negative control outcome or a negative control are things that are related to unmeasured confoundings, things that you did not include in your model and your outcome, but are not directly related to corticosteroid choice or your exposure. And so the importance of this negative control outcome is if you identify an association between corticosteroid choice and blood transfusion when you do not think one exists, then that's likely evidence that there's unmeasured confounding that's actually mediating this relationship here, because we don't think this exists in real life. And therefore, if there's unmeasured confounding here, there's probably also unmeasured confounding between corticosteroid choice and death. So it's a complicated concept, but it's really important, I think, to assessing the robustness of your results. All right, what did we find? We had 12 million patients to start. We ended up with 88,000 patients. Most patients in the US receive hydrocortisone alone, but there were some patients that received both hydrocortisone and fludrocortisone. Here's the table one. I don't want to go too much into this. There were a lot of covariables, and at baseline, most of those covariables were already relatively well balanced between treatment arms, but not all of them. And so the standardized mean difference gives you an estimate of how similar variables are to each other between exposure arms. Typically, people use 0.1 or 0.2 to say that they're relatively similar or less. Higher numbers mean less similar. And so the variables that were most dissimilar to start were things like whether or not people were able to take medications via an oral or intraoral route. And then also some of the hospital characteristics like teaching status. Being these variables being similar to start, I think does matter. You know, after you do your propensity score adjustment and models, all of these observed factors are accounted for. So the differences on this page don't matter as much for the characteristics themselves, but they do matter for unmeasured confounding, because I think the more evidence of difference between treatment groups before you do any fancy modeling is evidence that these exposure arms are different patients and that there's probably unmeasured confounding. So I think we were relatively happy that most of these were similar characteristics to begin with some exceptions. And to us, that suggested what we already knew, that providers and clinicians were idiosyncratically choosing between these two treatments. There wasn't really justification for one versus the other. People just thought that they were best. And they weren't saying, oh, I give hydrocortisone in some cases, and in other patients, I give hydrocortisone and fludrocortisone. We didn't think that that really was common, but I'm curious to hear how you guys do it. These are the primary outcomes. The numbers to focus on are on this adjusted risk difference. This is the comparison between combination treatment versus hydrocortisone alone, so that there was a negative 3.7 risk of death or hospice if you received hydrocortisone and fludrocortisone, and that seemed to be consistent or even higher in several sensitivity analyses that you can see below. So this graph is, I think, shows nicely a major limitation of our study. So this is an unadjusted survival curve. The adjusted survival curves with our TMLE method, I don't think exists as far as I'm aware of, but we weren't able to find any. So this is just the raw data. So take it with a grain of salt. But you can see here this is survival for each treatment arm over 28 days. And you can see that on day 0, the day that patients were started on treatment, either one of the treatments, there was already a difference in the rate of the outcome. And so there are two possible reasons for this, I think, mainly. One is that the fludrocortisone, the addition of fludrocortisone works quick. And so whatever the mechanism by which fludrocortisone improves in septic shock, it benefits people early, almost right away. So you give fludrocortisone and they do better. The other interpretation is that there is residual confounding, and primarily in the form of a mortal time bias, where that the patients who were receiving fludrocortisone were at the beginning of the study already less sick than the patients who got hydrocortisone alone. And so those possibilities are both possible. And I don't know what this curve would look like in our TMLE approach. What I would say is that those are both possible. And I hope we can get into some of the details of immortal time in this study later if you guys are interested. Negative control outcome of blood transfusion showed no difference. So that was strong evidence for us that residual confounding was less of an issue. And then we did a completely different thing. So the last analysis we performed is called a difference in differences design. It was not answering the same clinical question. It wasn't saying if a patient receives hydrocortisone or hydrocortisone and fludrocortisone, who does better. It was answering a different question. So if you were admitted to a hospital, that after the approaches trial, that a non-2018 trial that showed benefit from combination treatment, if you were admitted to one of those hospitals that chose to adopt fludrocortisone after that trial, then were your outcomes better than if you were admitted to hospitals that did not adopt fludrocortisone? So it's a nuanced study question. It's related to our study question, but it's not the same. But we did similarly find that if you were admitted to a hospital that chose to adopt fludrocortisone, your mortality was lower compared to those hospitals that did not adopt fludrocortisone. And the benefit of a difference in differences or other econometric based analyses is they are inherently resistant to a lot of that individual patient level confounding that the other analysis is. And so that's why we decided to conduct that. Here are what we think are the implications. It's basically bullet point one, that we think that the combination treatment is probably superior in patients with septic shock. And I think our results show that, but if you really review the results of existing studies, they pretty much support that too. And so I personally, this has changed my practice because I don't really see the downside of giving fludrocortisone. A part of me still does worry that it's not better, but I don't really see the downside. I think it raises the question about maybe corticosteroids aren't just working through or that fludrocortisone isn't just working through kidney mineralocorticoid effects. And there is some lab data that suggests that mineralocorticoid receptors are also in the lung. And so maybe there's an effect on innate immunity and the ability to clear fluid from the alveoli. So I think we need to move beyond thinking that fludrocortisone's only purpose is because it helps to retain salt. Limitations, the main one is bullet point one. It is a limitation in our study. I hope we can talk about it more. And other sources of unmeasured confounding, like all observational data, is also a limitation. We did calculate an E-value, which is supposed to estimate how strong a confounding would have to be, how strong of its relationship would have to be with the outcome and the exposure in order to nullify our results. And 1.32 means it has to be about 30% associated. So in isolation, that number is meaningless. It's probably a moderate confounder would have to be present to nullify our results. And what we're hoping to do next, we're hoping to use our results in a network meta-analysis as the prior probability. And so in Bayesian statistics, just like in clinical reasoning, we usually have some probability of treatment working before we give the treatment, and then we give the treatment and figure out if it works. So same thing here. We're hoping to use our results that show that this combination treatment is probably better as the prior probability of whether it's beneficial, then do the meta-analysis to see whether it's better, and hopefully get an answer about whether yes, no, if we incorporate both our results and the results of the RCT, if hydrocortisone and fludrocortisone is better. And oh yeah, and I'll say, just this is the last slide. Just last month, Anon and several investigators sort of did this. They published this in Decimo. So they did an individual patient level meta-analysis, and the primary purpose of this meta-analysis was to compare corticosteroids to placebo, not one corticosteroid regimen to the other. But they did do that in a secondary analysis. They compared hydrocortisone versus hydrocodone fludrocortisone, or hydrocodone continuous, like an infusion, versus hydrocortisone and fludrocortisone. They didn't use any Bayesian probabilities or prior probabilities, but it did look like that fludrocortisone had improved outcomes in general. None of them were statistically significant, but all were very close to statistical significance in favoring hydrocortisone and fludrocortisone. And this is my last reminder. This panel A is to remind me, in this same study, they took the survival curve of all of the trials of shock in the past, looking at corticosteroids, and you can see how different the survival probabilities are. And I think that just speaks again to the fact that septic shock is not the same. And what we probably really need to be moving towards is not yes, no, but who should get corticosteroids, and which patients should get it. Is it based on their predicted mortality? Is it based on other factors? And we don't really know the answer to that. And that's it. I'll thank those groups and be done, and I'm hoping we can discuss.
Thank you. Thank you very much for this presentation. And I give the chair to our audience.
So, my name is Giorgio Costantino. I work in the Polyclinic Hospital. Thank you very much, Nicolas, for your presentation. That is real brilliant, and for your study. My two questions are, so you start the presentation about the variation in practice of your friends, okay? Do you think that the friends that didn't prescribe Fludrocortisone now they prescribe it or not? This is the first question. The second is, do you think that this study is enough to change our clinical practice or not? Thank you very much.
Great, and I think those questions I think are related, and I'll give you what I know and then what I think. So those my friends have all changed their practice, but we are all part of this study. I'll also say that those that wrote the editorial for our study, including investigators at UCSF and Harvard, all said that they changed their practice. Whether it's enough, what I think is that the combination of our results and already the existing literature, I really want to emphasize that I think if you do a careful review of the literature, you can make a strong case for fludrocortisone anyways. I think what we have now, since we have to take care of a patient every day, I don't see the downside of giving fludrocortisone, and I think most patients should receive combination treatment. However, I think that there remains enough of a knowledge gap that it's possible that we will find, if someone can do an RCT that's that big to answer the question, it's possible there will be no difference. But I think the combination of the possibility of being no difference and really basically no side effects of fludrocortisone and existing data suggesting that fludrocortisone is better means that we should be using fludrocortisone. And so I hope that answers the question. I think for now that the evidence is in support of using it. I think it's possible that big picture, if we could do a trial of 10,000 patients, it might be that there's no difference. And that's okay, is what I would say. We are hoping to work with the REMAP CAP investigators, a broad multi-platform clinical trial. We've approached them about this potential study, and we're hoping to pilot it at least to see if it's feasible, and would be comparing these two regimens in pneumonia patients specifically, not all septic shock, and whether patients with severe pneumonia are the same as septic shock is also an ongoing debate, right? ARDS, septic shock, pneumonia happen together all the time, but whether some of those patients benefit from corticosteroids and not, we don't really know. Sure. Thanks for the question.
Thank you very much.
As someone who I always used hydrocortisone alone. That's always what I use. I just said, oh, well, the surviving sepsis guidelines say it's good enough for me. I'm curious to know if there's anyone who doesn't use fludrocortisone actively, like they think that there is risks of giving fludrocortisone. I know often mentioned is because it's given, there's no IV formulation, and so people are concerned about gut ischemia. But I'm curious if anybody says no, you know, fludrocortisone is going to hurt the patient. I haven't found that.
Because I think that is very interesting what you said, but in my experience, well, in Italy, it's not so easy to use Hydrocortisone because it is not always easy to obtain it. But the other thing is because your question before was why not using it? But for example, in Italy we had, but also in US, a lot of COVID, and during COVID, for example, we used many drugs that was absolutely not useful, and maybe, but we don't know, had some adverse effects. So I have some fear to use something if I am not really sure that it works, because on the same line of reasoning, we could use many things, and so the health system will, and the patient too will explode. So this is maybe my fear.
Yeah, totally makes sense. And I'm not pushing either way, and I think that's the important part of doing good research is I'm not trying to back up what I say. It's understanding why people do what they do. So that's great. Yeah, I am in agreement. We should do no harm, right? We should until it's proof.
Is there any other question? Maybe from, I don't know, Marcella or Sarah, if you have any open question after your debate of the last time.
Okay. Good afternoon. My name is Sara Bonfatti. I'm just start now to work like a doctor in emergency medicine in Bologna. And me with the other person that now is still working, so I'm the only available to stay here. But we presented the pros to your study, and it was really interesting to also study an article that includes something that for me, for example, like machine learnings and a lot of statistics could be a chance also to develop my knowledge in statistics.
Yes.
And yeah, I've got some question about the dose of hydrocortisone and fludrocortisone.
Yes. I think you cut out, or maybe I cut out.
No.
Oh my gosh.
Sarah? Sarah, we
Okay,
can
it's
see
work.
Okay.
We saw that the dose was hydrocortisone 20 milligrams and fludrocortisone only 1 tablet of 0.1 milligrams. So, but I don't really understand if this was just a tablet for 1 day, or what is this the timetable? I don't know of the drugs. And this is the first question. And the other questions is about your experience and probably also the United States experience in practical medicine. What type of person, what type of, I don't know, comorbidities also had this patient who had good outcomes with mineral corticoids? I know that there are some, I don't know, common characteristics. Thank you.
Yeah. Let me find it. So yeah, there's two questions there. The first one is about the duration of treatment with fludrocortisone, and was this a one-time or a multiple time? And so it's a great question, and that is a difference between observational studies, not all observational studies. I guess I'll take it back. If it's really easy observationally, I think, to compare starting one therapy to starting another therapy, because they happen at the same exact time potentially, and it's less subject to confounding and problems with the observational analysis. If you start to compare somebody who got 7 days of treatment versus of fludrocortisone to someone who got 5 days of hydrocortisone, the risk for time varying confounding, meaning on day 2 and day 3 and day 4, maybe there's a reason that patient didn't receive fludrocortisone. Maybe they died. Maybe they no longer had an IV access or no longer had enteral access. And so there's many things that can change over the course of someone's treatment that makes comparing durations really hard observationally. Versus in a trial has a protocol that says this patient will receive this medication for 7 days unless they're dead. And so the design of an observational study where you include duration of therapy is extremely difficult. So in our study, it's possible, but you need data that is granular to the minute. You need patient data that tells you about what happened on a minute by minute basis to do it well. And so in our study, we just said where you started on one treatment or started on another. We did look at how long on average people receive treatment, and it was about 6 days. But I don't want you to think that that means that 6 days of fludrocortisone is the right dose. It just means it's what people got. So strictly speaking from a statistical standpoint, our comparison was just starting one therapy versus starting the other therapy. And why we think that that's a reasonable comparison is, why would somebody start one therapy and then add the second one, right? It's not like somebody's like, I'm going to give hydrocortisone for 2 days, and then all of a sudden I'm going to do hydrocortisone and fludrocortisone. The second question about who should get it is unknown. And I think that's where we want to go next, is we need to identify which patients would benefit. And that's called heterogeneity of treatment effect. And often in clinical trials, those are subgroups. So when you see the subgroup part of a clinical trial that has that nice forest plot that shows you, and if your age is greater than 65, you benefit. And if you're less than 65, you don't. But the methods to look at heterogeneity of treatment effects are becoming much fancier. And so if you want to be a leader in septic shock and ARDS moving forward, if you can start to learn about some of the modern methods for trying to tease out who benefits, personalized medicine, that's where the world's going. So, and I'll put in the chat, this is a good, or I'll try to find it. There's a nice article in JAMA Open that tries to look at this for corticosteroids in particular.
Thank you so much. No.
Yeah, this one's worth reading. That's a machine learning method looking at corticosteroids and septic shock to try to figure out who benefits. And then there's a second one that's really good for this. I'll have to find the second one, but I'll make sure to pass it along. The other one's in COVID literature, looking at whether full dose anticoagulation helps or hurts patients and whether that depends on who the patient is.
Okay, thank you so much for the library.
Yes, thank you for the question too. Here's the second one, and the second one really has the new kind of modern approaches to doing this, to try to do personalized medicine.
Thank you very much. Is there anyone who wants to intervene?
As people are thinking also, I guess I would, I am also in the camp of not giving treatments to patients that are untested. I think what helped me in this case to decide to treat partially was recognition of our study, but it was also that like Anand in the approaches trial in 2018 already showed that compared to placebo, the combination of hydrocortisone and placebo reduced mortality. Hydrocortisone and fludrocortisone reduced mortality. So I think unlike so many of the things in COVID that hurt people, we already have strong RCT evidence that it helps people. And so I think that's what helped me to decide to change my practice, is as I thought that it wasn't the same. It wasn't this high risk medication that we haven't used. It's been used in trials and shown to be beneficial.
I don't want to force anybody, but maybe Marcella from the group of cons was.
Hi. Hi, we are Marcella and Angela from Udine. We make the contro part. Actually, you answer most of our questions. We wanted to ask, we noticed that Hydrocortisone has an enteral administration. So we were asking if you think that it is possible that doctors gave the Hydrocortisone to patients that were less serious. I mean, because there was easier to give them Hydrocortisone instead of people that were in worse conditions, so they couldn't take the medicine. Thank you.
Yeah, I think that's a fantastic question, and I think it is a limitation of our study. And I think other than immortal time bias, it's probably the biggest limitation. So I'm glad you found that out, and I think that's right. We did try to use that variable, whether patients could take any other medication enterally, like for example, maybe they were given a proton pump inhibitor or omeprazole for stress ulcer prophylaxis. So we use that variable to try to decrease the chance of exactly what you're saying. But I think you're right that if you are able to take medications through the mouth, then you may be less sick. And for a doctor that wants to give hydrocortisone and fludrocortisone, but they don't think that it's safe to give via the mouth, they may give hydrocortisone alone. And so that, what you just nicely outlined, that's called selection bias. Because the groups that we assign the treatment in our study may not be right. It may be that some of the patients who were assigned hydrocortisone actually were going to see fludrocortisone, they just couldn't. And that is the difference between an RCT and our study. Great point.
Thank you.
We still have some minutes if there is anyone who wants to say something or ask any other question. If not, we can also close our lecture today. Okay.
It's late there. You guys are having fun on Friday.
Yes,
Thank you so much.
You're welcome. And I hope this was helpful, and thanks for the invitation. It was a lot of fun.
Thank you. Once again, thank you, because it was really interesting and it was a pleasure to have you here. And I hope that we can have many other occasions in our future to meet and have this kind of discussion together. And so thank you. Thank you again for your time and for your work.
And
Okay,
if you come in Italy, tell us that we will try to help you in any way. Okay, Italy, I think is nice, so you have to come.
Same if you guys are in Boston, the same thing applies. Be happy to talk more. So thank you.
Thank you again, and thank you everybody.
Thank you very much.
Thank you so much. Bye bye.
Bye bye.
Bye.